Alterations in reproduction, disorders of the female reproductive system. Premenstrual syndrome is a group of physical and emotional symptoms that occur in some women prior to menstruation. It occurs 7 to 10 days before menstruation from an unknown cause. However, there might be a hormonal connection, such as too much estrogen or not enough progesterone, and their effect on the brain. It creates physical and emotional symptoms. Different foods and drinks can potentially enhance some symptoms, such as sugar, salt, caffeine, and alcohol. Some of these signs and symptoms that are experienced include weight gain, headache, pain, irritability, personality changes, and anxiety. A menstrual diary can aid in diagnosis of PMS. The classic finding is the client is symptom-free between menstruation and ovulation. Treatment will depend on the symptom severity. Hopefully, healthful lifestyle changes might be enough to affect appropriate changes, but it may also require hormonal therapy. True or false? The cause of PMS is hormones. This is false. Dysmenorrhea, DYS, remember from medical terminology, this means painful or abnormal. In this case, it means painful menstruation. The primary dysmenorrhea is idiopathic and has no abnormalities. Secondary dysmenorrhea is the result of another disorder. Symptoms include low abdominal pain and cramping, and we treat this with non-narcotic analgesics, heat, treatment of the underlying cause, and sometimes it can be caused of retroversion of the uterus. Various menstrual disorders include amenorrhea, A from med-term. Remember that means absence. So it is an absence of menstrual flow. Primary is the period of time before menarche. In other words, before a female begins her first menstrual cycle. Secondary will occur during pregnancy, after menopause, or removal of the uterus and or ovaries, and at times during lactation. Oligomenorrhea is infrequent menses. Remember, oligo means small or decreased. It's normal for adolescent girls to have oligomenorrhea until menstruation is well established. It can be caused by endocrine imbalances, stress, poor nutrition, or lean body mass. Associated conditions with oligomenorrhea may be polycystic ovarian syndrome, premature ovarian failure. This is basically a premature cessation of ovarian function in women that are younger than 40, caused by the body not responding to the follicle stimulating hormone or an autoimmune attack. It is usually diagnosed by a high FSH level. Polycystic ovarian syndrome. Just a minute here. Lost my place. Okay. The polycystic ovarian syndrome, there's multiple fluid-filled cysts in the ovarian follicles due to an imbalance of hormones It may cause infrequent or irregular menses and the failure to become pregnant. It is associated with obesity, insulin resistance, hypertension, and abnormal lipid or fat levels. Treatment will include oral contraceptives and potential surgery. The next term is menorrhagia. This is excessive menstrual bleeding or menstruation that lasts longer than 7 days, caused by endocrine or coagulation disorders. It is managed medically and surgically with NSAIDs, hormones, endometrial ablation, uterine balloon therapy, and photodynamic therapy. And then metorrhagia is unexpected irregular bleeding outside of the normal menstrual period. It does happen, or if it is intermenstrual or postcoital bleeding, this is called spotting. Spotting during ovulation is not considered to be abnormal. It is caused by pituitary or ovarian stimulation, uterine malignancies, and cervical irritation, or we may see some breakthrough bleeding with hormone replacement therapy. This type of bleeding always requires evaluation. True or false? Menorrhagia is a disorder where menstruation lasts longer than 7 days. This is true. Menopause is considered the cessation of the menstrual cycle, and we can also have physiologic or natural menopause or surgical menopause. The climacteric period is the time in which the ovarian function gradually begins to cease. A woman is considered postmenopausal if she goes a full year without menstruation. Surgical menopause would be the removal of the uterus and or the ovaries. Natural menopause usually occurs in women 45 to 55 years of age. So what is happening is we have a diminishing ovarian function, a reduction in hormones. There is that hypothalamic and pituitary stimulation that attempts to keep these cycles going. So the woman is going to start having irregular menstrual periods, alterations in temperature regulation, sleep disturbances, mood changes, diminished libido and or pain during intercourse, vaginal wall thinning, breast and uterine atrophy, and loss of bone density. Medically, we can manage it with hormone replacement therapy, antidepressants, biphosphonates, and symptomatic relief. We may also want to consider calcium and vitamin D supplements because as the woman reaches menopause, the decrease in the hormone production can lead to osteoporosis. So to help keep those bones strong, calcium and vitamin D would be very highly recommended. We can give the selective estrogen receptor modulators, or the SERMs, in our postmenopausal osteoporosis. We, of course, would not want to give this for pregnancy, or if a woman has pregnancy, or she has a history of or has a known clot disorder, because one of the adverse effects is going to be increased risk of venous clots. Now, she's postmenopausal, so we're basically going to kind of throw her back into menopause. So she's going to actually experience some of these same menopausal symptoms, such as hot flashes, and may also have leg cramps. It is a teratogenic medication, so it is dangerous to a developing fetus. These women may also experience leukopenia, which would increase their risk for infection. Of course, it interacts with other medications, and one of the common drugs that is in this category is raloxifene. So with the hormone replacement therapy, this is indicated for atrophic vaginitis, hypogonadism, ovarian failure, uterine bleeding, breast or prostate cancer, osteoporosis, or menopause symptoms. Again, numerous contraindications, but understand that this is one medication that increases the risk for cancers. So it should always be prescribed on an individual basis and should not be considered as being appropriate for everyone. Adverse effects do include blood clots. Basically, any type of hormone replacement, male or female, will increase the risk for blood clots. Please do not forget that. Hormone replacement therapy, male or female, increases the risk for blood clots. It can also cause photosensitivity, cardiovascular disorders, and dementia. So again, always look at the interactions with other medications. The types of drugs in this category would be your conjugated estrogen or estradiol. Again, hormonal replacement risks increases the risk for cancers. It can increase the risk for blood clots, strokes, dementia, gallbladder disease, myocardial infarction. So the decision to use hormones should always be made on an individual basis. Use of this type of treatment has decreased because of the high level of potential complications. So we always encourage these women to use lotion for skin dryness. They may require vaginal lubricants for intercourse due to the decreased vaginal secretions. Educational or exercise program, we need to maintain that bone strength and maintain body weight. Education on the increased calcium diet and when to call a physician. So vaginal lubricants are indicated postmenopausal for decreased vaginal secretions. These should always be water or silicone based, and they should not be petroleum based. In other words, we want it to dissolve at body temperature. Petroleum based will not do that. Endometriosis is a condition in which endometrial tissue is found outside the uterus, such as the ovaries, pelvic, or abdominal cavities. It's not clearly understood exactly why this happens, but this tissue, again found outside of the uterus, is going to respond to the hormones just as the tissue inside the uterus does. So when an ovum has not been fertilized and the woman begins to menstruate, it also causes bleeding and sloughing of that endometrial tissue in the abdomen. So it causes significant abdominal pain. It does result in adhesions and sterility. These women have severe dysmenorrhea, copious menstrual bleeding, and they may also have chocolate cyst formation. We can manage this naturally or surgically with menopause, because once a woman stops menstruating, this tissue stops sloughing off. Excuse me. We can remove any cysts. Hormonal contraceptives may be beneficial because it decreases the number of menstrual cycles a woman may have or helps control them. NSAIDs and heating pads are also beneficial. Nurses need to discuss pain relief methods, discuss the disease and treatment, and provide that education and emotional support. Excuse me. Pelvic organ prolapse is the protrusion of some of those female reproductive organs or the bladder or the rectum into the vagina or through the vagina. A cystocele is the bulging of the bladder into the vagina. Cysto, remember, has to do with the bladder. A rectocele is the bulging of the rectum into the vagina. We can also have a uterine prolapse where the uterus begins to prolapse into the vagina. Basically, this is caused by weakness in muscles from childbirth. There may also be weakness in the fascia. There might be urinary and bowel alterations seen with this. And we may see stress incontinence, especially with the cystocele, or constipation with the rectocele, cystitis with the cystocele. May feel like something's dropping out if there is a uterine prolapse. We can treat this with a pessary, which is a firm donut-shaped or ring device that is inserted into the upper vagina, and it helps reposition and give support to the uterus when surgery cannot be done or the client declines surgery. Teach Kegel exercises to help strengthen some of those muscles. May require some transvaginal repairs. Perineal care following urination and defecation is really important postoperatively, and these women may also require an indwelling urinary catheter for 2 to 4 days post-procedure. Nurses should educate the client on the pessary insertion and care, when to call the healthcare provider, maybe doing the knee-chest position to help reposition some of those organs, and avoid heavy lifting. True or false? It's common to use a pessary as a treatment for a rectocele. This is false. This is more for the cystocele. A uterine leiomyoma is a benign growth of smooth muscle, fibrous connective tissue. It's most common in the pelvis, also known as fibroid tumors. The growth of these tumors is actually stimulated by estrogen. If there is a small growth or slow growth, it doesn't happen very quickly, and it can happen in various sites. These women may be asymptomatic. They may also experience menorrhagia, which is most common, anemia, or dysmenorrhea. The tumor size will begin to shrink after menopause. Remember, it's fed by hormones. We secrete hormones pre-menopause. So after menopause, those hormones are no longer being secreted, so tumor size will begin to shrink. So if we treat with medications, we're actually going to medically uh, induce some menopausal symptoms. We want to encourage pelvic exams 2 to 3 times a year and a pap smear 1 to 2 times a year for these women, just to make sure that things are not getting out of control. It may require that dilatation and curettage where we scrape that tissue out. A myomectomy is the surgical procedure where only the tumor is removed. In severe cases, it may require a hysterectomy. Very important for we nurses to provide appropriate education. With cervical and endometrial cancer, these probably begin as a premalignant lesion that later undergoes malignant changes. Localized malignancy is referred to as carcinoma in situ. If it's untreated, it will subsequently invade other areas of the uterus and adjacent tissue. Cervical cancer is considered the second most common female reproductive cancer, and it is most common in women who are 25 to 50 years of age. Cancer of the endometrium affects the lining of the uterus, and this is more common in postmenopausal women. Risk factors include early menarche, late menopause, nulliparity, meaning no pregnancies, multiple partners, chronic cervicitis, and obesity. This can happen after a exposure to a drug called DES. It can happen with early and high-risk sexual activity, increased risk with HPV, smoking, and pelvic radiation. Bleeding is an early symptom with these cancers. Pain and pressure on the bladder are considered late symptoms because now the tumors have enlarged. Treatment is going to depend on tumor staging. It may require a hysterectomy. It may require chemotherapy. It is important for nurses to encourage that HPV vaccine, regular pelvic exams, and pap smears to help detect these issues as early as possible. Ovarian cysts and benign ovarian tumors. Well, what is a cyst? This is a membranous sac that's filled with fluid, cells, or both. And tumors are going to be non-cancerous growths of solid tissue. We really don't know what happens, what causes these cysts and benign tumors, but endocrine dysfunction has been implicated. It does affect menstruation and fertility. These women have menstrual irregularities, pain, lower abdominal discomfort, and backache. Treatment is going to range from no treatment to oral contraceptives to surgery. As nurses, we need to assist with pain relief and educate the client on any procedures, surgery, and postoperative cares, and encourage these women to continue to get regular pelvic exams and pap smears. Ovarian cancer is the leading cause of death from gynecological malignancies because they're usually well developed when they're discovered. So these are hereditary. They usually happen in nulliparous women, women who have never been pregnant, and other types of female reproductive cancers. Risk factors for ovarian cancer include the use of talcum powder on the perineum, a high-fat diet, again the nulliparity, infertility, being 70 to 80 years of age, having mumps prior to menarche, and of course a family history of ovarian cancer. These women early on may complain of a vague abdominal discomfort or urinary frequency, but later on may develop ascites and weight loss and severe pain. There are various surgeries that can be done, including an oophorectomy, which would be removal of the ovary, followed by chemotherapy. Nurses need to educate in preventative measures, especially for those women who are high risk. We know that at least two pregnancies will decrease that risk. Breastfeeding and oral contraceptive use for over 5 years will also decrease the incidence or risk of ovarian cancer. A hysterectomy is the surgical removal of the uterus and the cervix, and it may include all or a part of other reproductive and pelvic structures. The extent and the approach of the surgery will be dependent on the pathology and the client's condition. The vaginal approach for a hysterectomy does have fewer complications, a reduced recovery time, and lower cost. We can also do a laparoscopically assisted vaginal hysterectomy, which is a combination of surgical and endoscopic techniques being used to perform these vaginal hysterectomies that would otherwise have been performed abdominally. Preoperative care includes douching and an indwelling urinary catheter and an antibiotic. We do provide general postoperative care, and as far as teaching, we encourage the female to take medications as directed, avoid heavy lifting, douching, and intercourse postoperatively until it is okayed by the provider. We teach on any wound care, teach the woman to avoid constipation and straining, and when to call the doctor. And now the post-test.